Good morning. Welcome to today's discussion about the clinical applications of personalized in vivo pharmacology testing. I'm Dr. Jonathan Nakashima, Chief Scientific Officer at Certis Oncology, and today we're going to explore the current landscape of precision oncology with a panel of medical oncologists and try to answer common questions from other practicing physicians and their patients. We're joined today by thought leaders in cancer research and patient care. Dr. Arun Singh is a medical oncologist and associate professor in the Department of Medicine, Division of Hematology and Oncology at UCLA's David Geffen School of Medicine. Dr. Sandeep Patel is a medical oncologist and associate professor of medicine at UC San Diego Health. Dr. Noah Fetterman is the director of the Pediatric Bone and Soft Tissue Sarcoma Program at UCLA Medical Center and professor of pediatrics and orthopedics at UCLA's David Geffen School of Medicine. And our fourth and final panelist is Dr. Fritz Alger, a professor of surgery, Division of Surgical Oncology, with a dual appointment in the Department of Molecular and Medical Pharmacology. He is the director of the UCLA Sarcoma Clinical Translational Research Program within the Johnson Comprehensive Cancer Center. Welcome, doctors, and thank you so much for being here today. Let's begin this conversation with a quick overview of what we mean by precision oncology, a form of personalized medicine which we hear so much about today. We know that every cancer is unique, which is why a particular therapy may work well for one patient, but not for another with a similar diagnosis. Precision oncology seeks to match each patient with the right therapy, and we have a variety of tools to help do that. When first diagnosed with cancer, patients will almost always be prescribed what's known as standard of care for their diagnosis, and it varies based on factors such as cancer type and cancer stage. Typically, standard of care includes a combination of treatments such as surgery and chemotherapy and radiation therapy. These first-line treatments are often chosen because they have shown to have the greatest benefit when tested among large populations. Yet we know that individuals with cancer respond differently in different ways to different treatments. In some cases, the standard of care fails, stops working, or has intolerable side effects, and the patient needs to move beyond the standard of care to next-line treatments. Also, in many cases, genetic profiling will be performed to help identify key genetic features called biomarkers in the patient's tumor that indicate whether or not they might respond to a particular therapy. While genetic testing can provide valuable insights into a cancer diagnosis, treatment, and prevention, it cannot tell you whether specific mutations are driving that particular cancer and therefore has its limitations. There are also in vitro screens, which are essentially exposing a patient's cancer cells to treatments using a 2 or 3D culture model to evaluate drug response. Because these cells are in a plastic dish, in vitro screens are less physiologically relevant than other testing systems, making them much better at identifying treatments that won't work rather than what will. And finally, we have in vivo testing, which involves growing an individual's cancer in a living organism, in this case, specialized mice that lack an immune system, which allows the tumor to grow in a different species. These are known as patient-derived xenografts, or PDX models for short. These personalized mouse models allow scientists to simultaneously test multiple therapies in a living system. While this testing process typically takes about 4 to 6 months, from tumor biopsy to delivery of an individualized report, it's the most precise of all the tools we have in the precision oncology toolbox. At Certis, we take the PDX model to the next level using a methodology called orthotopic engraftment, which means we implant the patient's tumor tissue into the same organ it came from. This type of mouse model is also known as an orthotopic PDX model, or OPDX for short. And OPDX models have shown and demonstrated high concordance with human drug response. That's largely because they have the unique ability to mimic the patient's tumor structure and microenvironment, as well as metastatic behavior. The personalized in vivo testing is a two-step process at Certis. First, we conduct an initiation study. The sole purpose of an initiation study is to see if we can get the human tumor tissue to successfully engraft and grow in mice. If engraftment is successful, we then create many, typically several dozen models of the patient's cancer for the actual pharmacology testing. Once those mice are fully tumored, we dose each cohort with a different therapeutic option and measure tumor response. This allows us to understand the relative effectiveness of each therapeutic option, informing the next line treatment decisions. Now, I'm going to turn it over to Dr. Singh, so you can hear firsthand from expert physician scientists who are following the path to certainty and integrating personalized in vivo testing into clinical decision-making.
Thank you, Jonathan. So as Jonathan alluded to, the big aim of Certus and all these in vivo testing platforms is to really try to find the best drug for each individual patient. So it's the ultimate in personalized medicine. And really what we're trying to do is change the paradigm for which patients get drugs. The drugs that patients get treated with by their oncologist is based on historical clinical trials and what seems to work for the vast majority of patients. But that doesn't necessarily hold for each individual patient. We're going to start off a little bit about the philosophy and about how do we view personalized in vivo testing versus other forms of precision oncology. By that, we mean next generational sequencing, circulating tumor DNA sequencing, also in vitro testing of cell lines that are derived from patient tumors. I'm going to start with Dr. Sandeep Patel and ask him his ideas about personalized medicine and what are his viewpoints about the pros and cons of each of these.
Thank you. And I think, the key concept of personalized medicine is each person has a unique cancer and also unique context in which that cancer is treated. Historically, the biomarker strategies for treating these patients, in particular with advanced cancers, has revolved around viewing a static snapshot remote in time, most commonly a tissue biopsy that may or may not reflect the current scenario that is going on within the patient. And with the advent of novel targeted therapies and immunotherapies, the need to understand what's going on in real time for a given patient, context of the cancer, meaning the tumor microenvironment, the living interactions between tumor, stroma, and the cell in a dynamic fashion, I think is increasingly key and one of the advantages of an in vivo platform for a diagnostic in cancer.
Overall, I think that's kind of really one of the main aims of Certus is to really use xenograft testing because we think this is really the gold standard of preclinical testing. It's the last test that's done in the lab before new drugs are brought into the clinic, and it really affords advantages via which NGS testing or cellular testing are lacking. So I'm going to move on a little bit to the next question. And what types of cases do you view in vivo testing a clinically feasible option or not? So I'm going to move that to Dr. Noah Fetterman from UCLA to see what his thoughts are on this.
Thank you, Dr. Singh. And I think there are a wide variety of cancer cases where in vivo testing is feasible. Certainly, any patient that you're getting upfront tissue tumor biopsies, possibly circulating tumor DNA or circulating tumor cells in those patients that are recurrent. I generally treat pediatric cancer, solid tumors. And so most of these, we have large amounts of tissue upfront at biopsy. And in general, we're biopsying these patients on recurrence. The treatment for these patients is heavily protocolized, but as many of you know, we don't know which patients are going to respond, which patients are not going to respond, and those patients that are going to recur later on. And I think it's really important to be looking at these cases for response to therapy in an in vivo PDX model, and also those patients that are resistant to therapies that you know are going to need something else later on down the line.
It doesn't have to disrupt the standard of care. In fact, the patient should proceed with standard of care. But develop a model in parallel, do the sequencing, do the testing, and develop the model ideally, in a vivo model, is important because if it doesn't work, you have that access to these other informations, promptly. It doesn't mean that you shouldn't do the standard of care. so that it's not like you're disrupting what the patient should have happen, but it'll give you more information down the line if needed, which is often the case. Even in cancers that have good treatment responses, 20 to 30% don't respond to that drug. I mean, that's in a good drug. Having this information is important.
Yeah, I think that's right, Fritz. And a large proportion of our patients in pediatric and medical oncology will present with advanced stage disease. And those patients have, an 80 to 90% likelihood of progressing or recurring beyond frontline therapy, and will need second, third, and fourth line therapies. And really trying to educate ourselves into what are logical options for the next lines of therapy is important.
The only way to test, if you don't have one of these models, the patient, becomes the mouse. You're testing these drugs in the patient. It's nice to have a model so that you don't have to do that. It's nice for the patient, and it's a time sink for the patient too. They get a drug that work. It burns 3 to 4 months, if not longer, on a drug that doesn't work. So if you had a model, ideally, you could test these things out and you wouldn't have to do it in the patient. There's no question it's the gold standard. The perception in the past is that it's too difficult, takes too long, these things, which is just not the case, particularly if you develop this model earlier in the course of the patient's care. As Arun said, any company that's going to take a drug to clinical trial, this is what has to be done before it's approved to go into clinical trial, is in vivo testing in a live system. And there's no reason why this can't be done for an individual patient.
And to expand upon that, when we talk about personalized medicine, N of 1 clinical trials, the need for an in vivo dynamic testing platform, I think becomes increasingly key. Cancer, it's as much a verb as it is a noun, right? And in terms of reacting to that dynamism, the ability to have a living in vivo model, I think is key. And so when we're talking about testing, I think about complementary ways of assessing the tumor, right? And so you do tumor genomics, increasingly RNA-seq, immunomics, right? PD-L1 status, mutational burden, things like that. But these are all static biomarkers. They're a snapshot in a time. They're a photograph, right? And so the idea that we can potentially have a video to understand what the cancer is doing, something in vivo that's dynamic, I think may really represent a game-changing opportunity, especially when we start thinking about the potential need for personalized combinations based on tumor effects that can really only be captured in a dynamic environment.
I think that's well said. I think as you can see, we're all believers in this type of technology, and we really see a lot of the strengths that this technology offers. But I think we should focus a little bit on the next question: is what are the limitations of personalized in vivo testing? Dr. Patel and Albert and Fetterman alluded to this a little bit. Is that you can only technically biopsy. This is dependent on obtaining biopsies of patients. And so they are in some ways snapshots in time of the patient's tumor at whatever given time the biopsy is taken. However, you are allowed to, you can immortalize xenografts, and they can be used and tested multiple times, which you can't get with other technologies. But other technologies such as NGS testing are really also snapshots in time. So no matter how you do it, it's difficult to get instantaneous longitudinal data for patients. But I think we want to talk to Dr. Jonathan Nakashima a little bit to see what his thoughts are about the limitations about establishing xenografts. Can you establish a xenograft for every patient? How long does it take to establish a xenograph? And then are there other limitations with testing?
Thank you, Dr. Singh. So by and large, the more aggressive tumors are the ones that take better. Usually stage 1, stage 2 tumors don't take very well. Conceptually, it makes sense. The more aggressive tumor it is, the more likely it's going to grow in a different animal. So there's that one limitation. The second one is that they call it the issue is tissue. Sometimes a lot of the biopsies we get are small fine needle aspirates or core needles, which we have been actually very successful in generating mouse models for. What we do is we implant it in different locations in the animal, not just subcutaneous, orthotopic, in the subrenal capsule or in the liver. And these type of environments help promote the growth of the tumor. But in the case of precision oncology, as we've been talking about with NGS and in vitro, oftentimes patients will want to do all the tests, and then it's just a matter of where does the tissue get distributed. So oftentimes at Certis, when a patient is kind of running the full gamut of precision oncology, we get a very small biopsy. So that can be limiting as well. But as I said, we've had success with that as well. And as far as the timing goes, it's about we published in sarcoma, median time to establishment was 54 days or so. So that seems to hold true still. But obviously that's the median, and there's some patients that take up to 4 to 6 months. Some are pretty fast, some are pretty slow. So again, the whole concept of precision oncology, personalized medicine is each person's cancer is different. And we see this in the modeling as well, simply as how fast the tumors grow.
All right. So the next question is, well, let's say we establish a xenograft model for a patient. How do we think about choosing therapies? Maybe Dr. Patel can start with what do you recommend for patients, and how do you think about this problem?
Yeah, I think the goal for cancer patients to have as many good options, right? In the curative intent setting, you want aggressive curative options. In the incurable setting, you want effective therapies with a good quality of life associated with them as well, as much as in the curative setting as well. And so we struggle with the amount of tissue input in some scenarios, right? That's available with small biopsies. And then depending on the context, we sometimes struggle with the timelines to get meaningful results. Now, I don't view this as big an issue with an in vivo diagnostic, because it's actually recapitulating likely the tumor growth characteristics in and of itself. But I think the second point, and we do this all the time in oncology, is we do a test for later, meaning we have a standard of care therapy or multiple approved therapies, either with existing diagnostics or by histology. You order a test now that you'll keep in your back pocket to use later in the future. And that very well may be the context in which a living diagnostic such as this may be particularly fruitful for patients.
It's a situation that's constantly moving and different for every patient. When possible, we like to have as much information as we can. And so that means getting NGS sequencing, which isn't always possible in all patients, looking for potential oncogenic drivers. Circulating tumor DNA is one of the things that we have looked at for those patients that also may be becoming refractory to our treatments. And then, we can't test everything. I think that's important. There are thousands of drugs out there, and that's why input from the primary oncologist who has experience treating these patients is vital. And so those therapies that we might test in these in vivo models are standard of therapies, salvage therapies, and then exciting clinical trials that are available potentially to these patients. That's generally how I think about which therapies to test.
Yeah, I do also consider personally clinical trials that are available, and some of those agents in clinical trials we can obtain the compound to test in a mouse in many cases, not all cases. I also think about the sequence of therapies as well. I don't just think of the next therapy for the patient, but I'm thinking about 3 to 4 therapies down the line. And so, it does take a few months to get the information back from this mouse model. But I pick therapies I know are going to be 3rd, 4th line therapy for a patient, so that we have all this information up front should the patient progress. And that's what the goal of this is, to get more information, to get very personalized information for each individual patient.
I mean, more information is always better. I think that point has been made. problem is there's often a lot of noisy information. So you have a number of targets, you do organoids, and there's 20 drugs. The problem is in those sittings is you have to choose one or two therapies, and the patient has X amount of time. There's no way to confirm it really, except in the patient ultimately. And I believe that's where one of the utilities of the orthotopic model is that it'll give you the most accurate information. So if they identify a drug by sequence or organoids, and it doesn't work on my tumor in a live in vivo system, I'm not going to take it. So it allows you to hone that list down to the most accurate model. It's all good. And that information is definitely useful because it gives you ideas, but it's nice to be able to confirm it.
And to expand upon that a bit, Dr. Singh, I think you mentioned earlier, we all think about clinical trials for our patients because this is often the therapies that are on the horizon that could help them. One of the things we all look at in a clinical trial when we're presented, right, we just don't say yes to everything, is what the preclinical data looks like. And as you mentioned earlier, the last step often of data, the most advanced data that we're presented when evaluating a clinical trial is how the mice xenograft models did with the targeted therapy. And that's more at a population level. And so the idea that we could potentially do this at an individual level and kind of plan for therapies down the line once we're on the horizon of what standard of care therapies and standard clinical medicine can offer, I think is really unique because almost all the assays we have are directional and static, pointing at a future that's not tested and feeding back into the system. That's unique and an advantage of an in vivo system.
And Dr. Singh, could I give a personal example about how I've used, the Certus PDX to guide clinical trial therapy in one of my patients?
Of course, I think anecdotes are really important.
So we have a young girl who has translocation positive alveolar rhabdomyosarcoma, advanced stage on presentation, and the therapy for that is extremely protocolized, being treated on Children's Oncology Group therapy. You really cannot veer from that standard of therapy. But even with that, we know that these patients, at least 50% to 2/3 of them will recur later, and almost all of them will die. So we knew this was a patient at high risk of recurrence and death. And Certus, we had submitted Tumor to Certus for PDX modeling, and we tested a variety of combinations, one of which was an in-house clinical trial at UCLA that Dr. Singh and I are investigators on with a drug called mositinostat. And we identified that mositinostat in combination with vinorelbine was a winner in therapy for this patient. That was a year ago. This patient did well up front, but ended up recurring several months ago. We put that patient on the vinorelbine and mositinostat clinical trial, and now at her first response scan, she's had a beautiful partial response. So I think that is a really good example about how to use one way that you can use this PDX model to guide therapy, not necessarily up front, but when you know the patient is going to recur.
Yeah, I think that's a great point. With regard to therapies, for the last 100 years, we've had chemotherapies, and then in the last 20 years or so, we've had a variety of targeted therapies that come on board. And more recently, we're in an era of immunotherapy now, and so a very common question comes up as well: can you test immunotherapies in these mouse models? The mice are immunodeficient. Are there ways to test immunotherapies in a meaningful manner? So for that, I'm going to start with Dr. Nakashima because he knows more about this than everyone else. So Dr. Nakashima.
To your point, Dr. Singh, that is one of the limitations of the system currently right now, although we're working on ways to remedy that. So as you pointed out, these mice are immunodeficient, so they don't have an immune system. However, what has been shown in the literature is that the first initial engraftment of the tumor still retain, in some cases, enough immune cells that you can test immunotherapies early on. Certus, we're verifying that right now to see if that's possible within our method with the passaging. Another thing that we're exploring is what's called autologous TILs, or autologous tumor infiltrating lymphocytes. This is where when we take the tumor from a patient, not only do we engraft it in the animals, but then we'll actually put it partly in culture and isolate the immune cells out of that tumor. By doing that, we'll have now the model growing in the mouse, as well as the immune cells growing in a dish. And what we are planning to do is connect those two back in the mouse model. So that way it's called humanized mice. It's where the mouse has now been given a human immune system. So by doing this, we can take the patient's immune cells from the tumor and graft it in the mouse, so it's expressing the patient's own immune cells, as well as the tumor. So then we can try a variety of immunotherapies that way. But that's still in development. So unfortunately, we're not able to perform that yet for patients. It's still in a research mode.
The other type of immunotherapy that really has come on board for, or still kind of in its infancy rather, is the use of NK cellular therapies. And I know we've done some work with companies that are looking to test novel NK therapies. Do the NK therapies require an intact immune system or not?
That's a very good point. Yeah. So NK cell therapies, cellular therapies, CAR Ts. This is all an emerging, booming field. So in that case, in those particular cases, you do not need an intact immune system. So we've worked with companies where we've tested this in our models, and we've seen in some cases good responses. The scientific question from there is, how does an intact immune system affect that differently, though? So that is a question that we're trying to sort out. Again, with the new generation of what's called humanized immune system animals. So that is a possibility. I believe the clinical readiness of cellular therapeutics is not quite there yet, at least to test in the mice first to then apply for the patients. But it's a very exciting field because it's a rapidly evolving field that we're, so to speak, riding that wave and trying to incorporate those therapies for our patients.
So the current status is that we're trying to give these mice an intact immune system and make them immunocompetent to do this type of testing. I'm going to ask Dr. Patel a really hard question. So let's say the next year we're successful and we can give every mouse an immune system and go about testing immunotherapies. Dr. Patel, what's the current status of the specificity of immunotherapies? Can they really be personalized? What are your thoughts on that?
Yeah, no, I think it's a great question. And I think really it shows the power of the system. Oftentimes, a drug is only as good as its diagnostic that kind of points you towards using the drug. Mm-hmm. And really one of the unique aspects of immunotherapy in particular, whether we're talking about cellular immunotherapy, which oftentimes is a bespoke product, right? CAR T cells are literally made from a patient's own cells and given back to that patient. Or even off-the-shelf strategies, depending on if we're talking about the NK part of the immune system, the innate or the adaptive part of the immune system, where it's actually engineered to fight a specific, clonal neoantigen, for example, or target. I think the ability to observe the potential benefit in a dynamic system, I think, is key. And our diagnostic tools are even more wanting in the era of immunotherapy. Currently, we'll use things like PD-L1, maybe tumor mutational burden, but these are really shadow biomarkers for the actual immunobiology, which is what's going on in the cells. And that's not something we can yet really address adequately in a dynamic environment. And so in vivo tools, I think, are key. And when you look at some of the seminal experiments done to bring immunotherapy, whether they be cellular immunotherapy or immune checkpoint blockade like PD-1, PD-L1 inhibitors in the field, the last step, even for those drugs, is mouse models. They're just slightly different than the mouse models we use for genomically guided therapy. And so I think this is really an avenue I'm excited about and will hopefully help patients not only on a population level, but on an individual level as well.
Thank you. I think that's a very concise answer. I think we're going to switch a little bit now. I think if we establish a model, we have a variety of drugs we want to test. But I think there's a lot of issues with that are currently happen both in our clinics as well as in the hospitals we work in. In terms of the workflow of getting a patient's tumor to Certus to get it tested. I think Dr. Albert probably has the most experience with working through the limitations in our very rigid hospital systems that we work in terms of getting tissue to a private company.
Yeah, I mean, I think that's something actually I've been dealing with for years. People have initially wanted to send stuff off for sequencing. There was interest in organoids, the in vivo testing, or Certus or other type of companies. At the end of the day, if the patient wants that done, there's a mechanism for that 100%. I mean, it's not the hospital or hospital system really can't deny that ability to that patient if they want to send a patient a tumor. Now, it's not always easy, and you have to jump through a lot of hoops. As a surgeon, I'm a central person for that because it's easy to get a piece of the tissue. I coordinate with pathology, but the patients have a consent for whatever company that wants that tumor, and usually some sort of transport mechanism. It's surprisingly easy, and it doesn't disrupt the pathology that needs to be done or any of the tests at the particular institution. So again, similar to this testing doesn't have to disrupt standard of care. It certainly does not disrupt the ability to perform pathology or diagnostic tests that need to be done in that setting. So I think it's a lot easier than people think. And at the end of the day, if the patient really wants it done, the hospital or hospital system is not going to fight that. And we've been sending a tissue out, I would say, for over 10 years now, consistently. I mean, it's changed over the years, but the ability to do that is easier and easier, and it's more part of the workflow per se. I would say about half of my patients, maybe not quite that, but a significant number want a piece of their tumor sent somewhere for additional testing at this point.
I agree, Dr. Albert, that certainly this is not as complicated as we need to make it. If a patient wants their tumor tested, they get a biopsy. The biopsy is dropped into a vial of fluid and put in a box and FedExed to Certus. It's a very simple process. And the only thing, I think the only limitation I kind of see in terms of workflow is it does take a little bit of time on the oncologist, from the oncologist team to fill out paperwork and to really counsel a patient about how the process works. But that's no different than doing NGS testing or organoid testing or other personalized testings that are done. And in many ways, this is a lot faster than some of the other testing technologies that are out there as well. I don't know if Dr. Patel had any other words or that sums it up pretty good.
No, I think it's a great point, and we want to make sure these tests are accessible and available to patients. And so I think it's a great point, and especially for unique tests that can really meaningfully direct care. It's so key that we're able to potentially get these for our patients, and I think we're starting to see some of the potential use cases.
I have a question for Jonathan, actually. Say I take a tumor and I send you guys, the patient wants to generate a model. You guys do. It becomes immortalized. Say the patient wants to send it, I want to have sequencing. I want to have organoids done. I want it from that model. It's my tumor. Do you guys do that? Have you done that? Do you do that for patients? So you can do the testing for these other things from the model that you guys generate.
Yes, in some respects we have. Mostly it's with the primary tissue, and we would advise that when we get, a large sample, some of it goes into the animals, goes into kind of all of our test arrays, but we also bank some of the primary tissue for that patient, and cryopreserve it, flash freeze it. So that way that patient, if they want to send it out for testing in some other platform, we can do that as well.
The other thing we need to talk about is the cost of all of this. In an era where financial toxicity to patients is a real concern, where does personalized in vivo testing fit in?
Well, when we helped form Certus, this was done to help patients identify therapies for them. It was very much a patient. We very much wanted to be on the side of the patient, and one of the aspects of that was we wanted to minimize the charge for establishment or development of the model. In other words, you weren't paying for a large lump sum of testing if the model didn't grow, right? So the expense aspect of this was something that we considered, and we make, the cost for testing is irrelevant if the model doesn't grow. So minimizing that upfront establishment of the model were some of the ways that we felt would help mitigate the cost expense for the patients.
Can you gentlemen speak to maybe the hidden costs we find, giving the wrong drug, or if
yeah,
or a drug that wouldn't work if you didn't have a model to decide upon? What are some hidden costs in oncology that patients don't see?
Certainly, if a patient had 3 drug choices, and the current standard care would dictate they go from A to B to C. But if actually drug C was the best from the group, they would have to go through drugs A and B before they got to C. So beside the financial cost of going through ineffective therapies A and B, there's a huge personal cost as well of receiving the side effects of drugs A and B before getting to the actual active drug C. So it's not only a financial cost, but it's a real personal cost as well. And that's where, but that's the current standard of care. And that's what we're trying to change and trying to get patients individualized testing.
Yeah, Arun and I have had patients we've treated together where they were on the standard of care and they had simultaneously developed a model. We found out based on the model very relatively early in the course of their standard of care that it wasn't going to work.
We found some other interesting anecdotes too, that for instance, a patient who'd been through 6 or 7 lines of therapy, we found out that their original line of therapy was still very active. And in modern oncology, many oncologists would discard drugs that were previously used. But a patient went back on their 7th or 8th line of therapy, went back on their original drug and responded for nearly a year, where they had no other good therapeutic options. So there's a lot we're learning about this. I think the last question we have is, what advice do you have for oncologists who have never used personalized in vivo testing methodologies such as xenograft testing or organoid testing? Maybe Dr. Patel, you want to start?
Like any new technology, there's a learning curve, both in terms of ordering it as well as understanding it. And even, from the surgeon who collects a sample to the pathologist that may have a preparation step to, working with the company. These are all things that, we've had to do it at one point initially, whether it be next generation sequencing off frozen tissue decades ago, single cell RNA-seq to kind of understand at a single cell level what the RNA in a given cancer cell is doing, or an immune cell. And so I think just understanding the process, understanding the potential value for a given patient in the right context, as we discussed earlier, I think is key. And I think, fundamentally, it's harder to understand a more complex test, but it's much more meaningful to the patient because you can really glean information you otherwise never would have. For example, your anecdote about retrying a prior therapy or using a targeted therapy with chemotherapy, which you otherwise may not have the ability to get that information. And so I think at the end of the day, we're looking for good options for our patients, and we're looking at the problem in as many different angles as possible. I think in vivo testing is likely one of the angles that may be more fruitful, especially for particular targeted therapy considerations and, as you mentioned earlier, immunotherapy considerations.
I've been at the interface of this for a number of years, and I think a couple of key points, and I talked about it before. This does not have, just because you want the patient or people involved in the patient's care want to do this stuff, so it doesn't mean that it needs to disrupt what the oncologist thinks is the next best step. It doesn't have to disrupt the standard of care. It can be done in parallel. And I think in that situation, once they realize that you're not going to hang your hat on this one particular test, you're going to do it in parallel, and the oncologist can still do what he thinks is correct, which should be done. It's less disruptive in that setting.
I think certainly overall, the more information you have to help treat a patient who is undergoing therapy for cancer, the better. And also, Fritz and I, over the years, there's never been a single patient who said, this is not a good idea. More information, it's a better idea of which drugs would work or not just would work or would not work. It's just crucial information for patients. And for a patient to see that, it's amazing. They have a personal, they can be more involved in their therapy and in picking therapies. They can, and having more information just gives more power to the patient.
I think that's an excellent point. I mean, normally a patient is just told here's the next step for you. They're not like participating in this process. And it's something interesting that came out of some of the original studies we did, because I specifically would consent patients. I always consent patients for, take a piece of tumor to do research on. But when we were doing the original, kind of mouse model establishment studies, I would say, if you agree, we'll try to establish a model. But the patients asked about the model. They're involved in the process, and they were interested in it, and coming up with decisions and stuff like that. So the participation in that process by the patient was very rewarding, and I think Arun touched on a good point there.
Thank you to the cancer thrivers, care partners, and care teams, oncologists and cancer researchers for joining our interactive webcast today, and for joining us in our mission to connect every patient to the right therapy for their cancer the first time, every time. For more information on personalized in vivo pharmacology testing, please contact us directly or visit our website.